Hi, my name is Charles Weijer, and I'm a philosopher actively working to improve the health of Canadians. Canadians depend on health research. We need health research to develop and improve new treatments for high blood pressure all the way through to COVID-19. Randomized controlled trials in which patients are allocated by chance to a novel treatment or a comparator play a key role in ensuring that new medical treatments are based on a rigorous evidential foundation. But randomized controlled trials suffer from a problem called research waste. All too commonly, initial medical findings in trials don't pan out into improvements for patients in clinical practice. Of the $240 billion spent globally every year on health research, as much as 85% is research waste. What causes this? Randomized controlled trials may suffer from design flaws, as when we use a surrogate measure, like looking at a change in blood pressure, instead of the health outcome that we're actually interested in, like reducing deaths from heart attack and stroke. Also, promising findings in randomized controlled trials may fail to translate into clinical practice. The results may not be quite what we saw in the trial, and the reason is that patients in the trial are simply not as diverse as those in clinical practice. So if research waste is the problem, what's the solution? The solution is pragmatism. Pragmatic, randomized controlled trials aim to include all patients who would receive a treatment in practice. They're conducted in primary care settings with as few changes as possible, and they provide us with a solid evidential base as to how a treatment will work in the real world. But wait. Research ethics guidelines were written with traditional trials in mind, and they may be very difficult to apply to pragmatic trials. And this means that researchers may not have adequate guidance. It also means needless delays as research ethics boards struggle to review these studies. I am co-leading a research team, and our team is seeking to provide ethical guidance for pragmatic trials. The team that I co-lead comprises 28 philosophers, trialists, and biostatisticians from 5 countries around the world. Our work includes a massive systematic review of over 4,000 published pragmatic trials. We're also working with patient partners. We're working with patient partners to learn about their experiences participating in pragmatic trials. And we're working on difficult ethical problems. What are we working on? Well, let me briefly name 3 problems. The first is the fact that pragmatic trials tend to blur the distinction between research and practice. They're conducted with usual care interventions. They often take place in primary care settings, and they can use routinely collected health data. With this blur of boundaries, which ethical standards should apply? Second, informed consent is a keystone in research ethics. But if pragmatic trials involve usual care treatments that patients may receive in practice anyway and rely on collecting routinely collected health data, then is informed consent needed? And if so, for what? Third, as I've mentioned, pragmatic trials seek to include all comers, seek to include all patients who would receive a treatment in practice. And this means pragmatic trials will include vulnerable people And simultaneously, it means those vulnerable people are harder to identify. So how should pragmatic trials protect the vulnerable? Well, our journey has just begun, and we've got a lot of work to do. But our goal is to produce the world's first ethical guidelines for pragmatic randomized controlled trials.